Okay, so okay, then we have to see the risk and benefit of operative hysteroscopy, and we need to discuss the different type of endometrial ablation. Uterine artery embolization, there is full blown guideline on uterine artery embolization, and also MRI guided focus ultrasound ablation. We just need to know that this is another option. And then we have to consult the patient accordingly about benefits of medical and surgical treatment. Okay, so there is a referral system here for the complex cases. We need to refer those cases for detailed evaluation. Also, there is a referral pathway and local protocol. If abnormal uterine bleeding or abnormal findings are identified, I will tell you what is that pathway. This is very important. Whenever there is, for example, in the exam, if they are asking you, I remember this question came to me that if the patient on the because they have one stop clinics for postmenopausal bleeding. So if the patient have endometrial thickness, they have done they have done TVS and endometrial thickness is 6. So what will be your choice, urgent referral or referral within 2 weeks, or like that they were asking. So you need to know any patient specialist review of suspected gynecological cancer pathology within 2 weeks of general practitioner referral, it should be seen. So you need to refer these patients urgently, but urgent, even urgent from GP to specialist care, it takes 2 weeks. Okay, and if for urgent GP referrals, if you're referring the patient which is if it is for urgent GP referral, it is 62 days total from the date of referral till the patient receive the treatment. Total 62 days for urgent referral, urgent urgent intervention. And if it is a non-urgent GP, till the date of GP will refer the patient until the patient receive the treatment, it should be 126 days. So they have the pathway and they have the deadlines. Okay, so if any urgent referral, the referral should be accepted and reviewed by specialists within the 2 weeks, and the patient should receive treatment within the day of referral. Until 62 days she should be treated, whatever either she has cancer or whatever it is, within 62 days of this referral she should be treated. So this is called a referral system. So we have a normal menstrual cycle. We are dividing the menstrual cycle. We are actually describing the menstrual cycle, frequency and regularity and duration and the volume. So now this is from I took from strategy, the latest strategy. They told that now the normal range of menses is 24 to 38 days. This is the normal now, from 24 days to 38 days. And then there is a regularity. Regularity is the cycle length. If the cycle length is the number of the days from the first days of bleeding in one menstrual cycle to the first day of bleeding in the next. So this is a total cycle length. So no more than between 7 to 9 days difference between the shortest to longest cycle. For example, one cycle is 24 days, another cycle is 38 days. So the difference between the shortest and the longest cycle should not be more than uh, 9 days. Okay, so if shortest cycle is 24 days, then you can see that 9 days, how many 9 days, it should not be more than that one. So this is the regularity and this is the cycle length. If it is more than 9 days, that means she has oligomenorrhea, she is having a prolonged cycle. If it is less than 7, that's mean it's you can divide the definition accordingly. So duration, if it is less than or equal to 8 days, it is normal. But if it is more than 8 days, that's mean it is heavy menstrual bleeding or it's a heavy flow. So this you need to know that this is 8 days. Okay. So volume, now volume is a subjective definition, and if it is not interfering with the woman physical, social, emotional, or quality of life, then it is not. It is normal for that patient. So what we are knowing before, that 80 ml, more than 80 ml, but normally in normal menstrual cycle they say that 30 to 50 ml is normal. If you will you want to quantify it, 30 to 50 ml, but 80 ml in the one of the questions, latest questions, they are asking 80 ml, she is having blood loss of 80 ml, so that means she has heavy menstrual bleeding. So more than 80 ml or 80 ml, even subjectively it is more. So normal is around 30 to 50 ml. Okay. So abnormal uterine bleeding, we have to go now. Terminology is there is absence of menses, then it is amenorrhea primary or secondary. If patient you want to quantify, it is infrequent menses, then it should be more than 38 days, and it is frequent, it is less than 24 days. Why I entered these definition? Because these are the latest definition. Before what I know that more than 35, but now they are saying more than 38. And before it was 21 days, now it is 24 days. Okay. So regularity, irregular cycle, but when you label the cycle is irregular, that's mean there is a variation, 10 days variation between the cycle. Cycle length is the number of days from the first day of one menstrual cycle to the first day of the next cycle. So if it is more than 7 to 9 days, then mean it is the variation is 10 days. That means it is an irregular cycle. Prolonged cycle, it is more than 8 days, it is prolonged cycle. And volume, heavy or light, it is subjective definition. Okay. Now you have to see they divide accordingly. They divide acute non-gestational abnormal uterine bleeding. Patient is presenting to you in the ER with heavy bleeding and she is not pregnant. So this terminology is acute non-gestational abnormal uterine bleeding. Okay. So they define is an episode of uterine bleeding in a woman of reproductive age with sufficient quantity to require immediate intervention. For example, according to subjective, to prevent the further blood loss. So this is called majority of cases in gynae emergency. They are presenting like that. The patient is presenting to you with heavy bleeding. That's why she's coming to the hospital. So it is called acute non-gestational abnormal uterine bleeding. Majority of patients are presenting like that. So there are chronic non-gestational abnormal uterine bleeding. It is a reproductive year bleeding from the uterine corpus that is abnormal in duration, volume, frequency, regularity, and has been present for the majority of the preceding 6 months. So any patient who come to you in the OPD with the bleeding, with the irregularity of the bleeding, which include duration, volume, frequency, then for more than 6 months, then you can say that she has chronic non-gestational abnormal uterine bleeding. So these definitions are important when you are solving the questions and you are answering the treatment. Okay, so intermenstrual bleeding, there is a TOG article also on the intermenstrual bleeding. We will, it is the latest TOG article. We will see that one also. When abnormal uterine bleeding occur between well-defined cyclical menses, the symptom is called intermenstrual bleeding. Okay, so you can divide this intermenstrual bleeding subdivided into cyclical mid-cycle intermenstrual bleeding. Okay, you can divide like that because sometime around mid-cycle there is a small frank vaginal bleeding. Okay, and it can be physiological because due to the nether in the circulating estradiol levels at the time of ovulation. At the time of ovulation, estradiol level increases and then decreases. So that's why they said maybe sometime there is a bleeding. So you can say that it is a cyclical mid-cycle intermenstrual bleeding. So this is new terminology. So, or you can say that cyclical pre or post menopausal. So, there is another category, cyclical pre or post menstrual intermenstrual bleeding. So, what is the cyclical intermenstrual bleeding? That predictably occur either early in the cycle, follicular phase, or late luteal phase. Okay. So, and typically present as very light vaginal bleeding for 1 or more days. So they divide it cyclical, pre or post menstrual. You can predict that every month she will have either before the cycle, she will spotting, or either after the menses, she will have spotting either in the early follicular phase or the luteal phase. So it is called the cyclical intermenstrual bleeding. Or acyclical intermenstrual bleeding, you cannot predict what time the bleeding can occur. So mostly like submucosal fibroid patient can have spotting any time in the cycle. Then there is a postcoital bleeding, non-menstrual, which is defined as non-menstrual genital tract bleeding immediately or shortly after the intercourse. Okay. So these are the some of the new definition. So key point is menses is controlled by the cyclical hormonal changes in the menstrual cycle. Normal frequency is between 24 to 38 days. Normal duration is 4.5 to 8 days. Normal volume is 5 to 80 ml. If in the exam more than 80 ml, because in the strategy it's written that the normal cycle flow, menstrual flow is 35 to 50 ml. Okay, so if it is 80 ml, it is heavy bleeding. It's written in the one of the questions, the key is like that. So normal volume is between 5 to 80 ml, and the regular cycle to cycle variation is between 2 to 20 days. So this is a cycle to cycle variation is 2 to 20 days. Okay, so now we have to see the heavy menstrual bleeding, the NICE guideline. NICE guideline define heavy menstrual bleeding, which is cyclical and which is regular cycle. It is defined as excessive menstrual blood loss that interfere with the physical, social, emotional, and or material quality of life. And then the classical objective criteria of blood loss greater than 80 ml per cycle using lab or this pictorial assessment chart should no longer be used in the clinical settings, however, may be applied for research purposes. So any blood loss greater than 80 ml or pictorial blood loss assessment chart, it is no longer used because patient will tell you that her quality of life is disturbed, then you will take it as a heavy menstrual bleeding. Can you see my screen now?
No.
I think today, I don't know what's the problem, but there is some problem from my side. Anyhow, I will continue. I will see what I can do. I will pause. Just let me finish this one. Okay.
Yes, we can see your screen.
Okay. So menorrhagia. Okay, thank you. Menorrhagia, now no more use. Instead of menorrhagia, we should use heavy menstrual bleeding. So oligomenorrhea, they are not using. It's no longer be used. Okay, oligomenorrhea also I was using oligomenorrhea, but it is no more in use now. And polymenorrhea, metorrhagia, dysfunctional uterine bleeding, all of these terminology now it's obsolete. Now we have menorrhagia. We are using heavy menstrual bleeding, and oligo and polymenorrhea, I think maybe for all this one method, this one the it will be come under category of abnormal uterine bleeding. Okay, so prevalence of abnormal uterine bleeding, it represent a common and often chronic and debilitating condition for women. And the subtype of abnormal uterine bleeding is heavy menstrual bleeding. It is affecting the 14 to 25% of women of reproductive age. This is important figure because I took from NICE guideline, and it's written there. It's the heavy menstrual bleeding. The prevalence is 14 to 25%. That's mean every fourth woman, 1 in 4. So out of 4, one woman is suffering from this problem. Okay, so 14 to 25%. Heavy menstrual bleeding is one of the most common reason for gynecological consultation in both primary and secondary care. So again, the most common reason is not abnormal but heavy menstrual bleeding. This is the difference. So abnormal uterine bleeding prevalence is 14 to 25% abnormal uterine bleeding, and out of this abnormal uterine bleeding, heavy menstrual bleeding is one of the most common cause. Okay, then about 1 in 20 women aged between 30 to 49 years of age consult their GP each year because of heavy period or menstrual problem, and menstrual disorder comprise 12% of all referral to gynae service. So 12% of all referrals to gynae services are occur because of heavy period or menstrual problem. So this is another figure. 12% of referral to gynae is because of abnormal uterine bleeding. Okay, so this is referral. Okay, now I will start the heavy menstrual bleeding NICE guideline. Okay, this is just to tell you the terminology. And also, you know that there is one more thing going on, that FIGO changed the classification of ovulatory disorders. So we will later discuss this one. Oh, I will escape this one. Just 1 minute.
Ma'am, are you there?
Yes, yes, I am just searching the Microsoft. Wait, I need to check. Sorry for those. Today I just came from outside and I am not at all organized. Just let me. Okay. Can you see my screen now?
Yes, ma'am.
Okay. So this is NICE guideline. It is 2018 NICE guideline, heavy menstrual bleeding assessment and the management. How you are going to do assessment, the management. Okay, just 1 minute. Okay, so what is the impact of heavy menstrual bleeding on the woman? You have to understand that there is a major impact on women quality of life, and any intervention basically aim to improve this rather than focusing on blood loss. So you have to improve the quality of life of the patient. Okay. So what you need to do, history, physical examination, and laboratory test. Okay, just please mute yourself. Who is not muting? Just everybody mute themselves, please. Okay, so what laboratory test we will do? Okay, first of all, we need to take the history. In the history, we will take the nature of the bleeding. We will ask that what type of bleeding it is, abnormal uterine bleeding, but what type of bleeding it is. Then we need to ask the symptoms. What is the symptoms? If she has a persistent intermenstrual bleeding or pelvic pain and or pressure symptoms that might suggest uterine abnormality, uterine cavity abnormality, histological abnormalities, and adenomyosis or fibroid. So with the history, it's very important. Why? Because when you ask the history, patient will tell you, then you can make a guess that this patient is having an abnormal uterine bleeding because of bleeding of endometrial origin, or maybe she has some structural abnormalities because she has pain or because she has intermenstrual bleeding. Because character of the symptoms will tell you whether you need to do examination or ultrasound or no. So this is very important. History is very important. Then you will decide even you need to examine this patient or no, or even you need to do ultrasound for this patient or no. So you need to see also impact on quality of life, and then also you need to see other factors that may affect treatment options such as comorbidities like she's hypertensive, diabetic, or if she has previous treatment for heavy menstrual bleeding. So this is important in history. Also, you have to take in account that is this heavy menstrual bleeding or is this a patient perception, because there are variability in the menstrual cycle and blood loss, and also you need to discuss this variation with the woman. If the woman feels that she does not fall with the normal ranges, discuss the care options. So the woman will tell you, is it normal for her or is it abnormal for her? And also, if the woman has a history of heavy menstrual bleeding without other related symptoms, what we will do, she will just tell you that every month she has heavy menstrual cycle, but no pain, no intermenstrual bleeding, no pressure symptoms. Then you will consider the pharmacological treatment without carried out physical examination, unless you decide for this patient, Myrina. Okay, please mute yourself. Anyone, because somebody is continuously I can hear. Mute all. Okay. Okay, now better. Okay, so what we need to do, we will, if we will decide for her, okay, looks like she's just having heavy menstrual bleeding, no pressure symptoms, no intermenstrual bleeding, nothing. So unless we want to put for her Marina, we will not do even offer her physical examination. This is very important, because now when you have EMQs, then you have to decide the treatment option or the management option accordingly. So that's important, that if the patient is just having without any symptoms, looks like low risk, no ultrasound, no physical examination, just give her first line treatment. Okay. Oh my God. Okay. So, physical examination, if the woman has a history of heavy menstrual bleeding with other related symptoms, offer a physical examination. And also you need to do physical examination if you want to put the marina. Okay. So laboratory test, what you will need to do, you will do CBC for all women with heavy menstrual bleeding in parallel with any heavy menstrual bleeding treatment offered. And also you will only consider for coagulation testing, for example, von Willebrand disease, if the patient have heavy menstrual bleeding since their period started and have a personal or family history suggesting a coagulation disorder. Only these cases you will offer the coagulation profile, otherwise only offer the CBC for all patient who is presenting for heavy menstrual bleeding. Okay. So what you do not carry out serum ferritin test, do not do female hormonal testing and thyroid hormone testing unless other signs and symptoms of thyroid disease. So routinely female hormonal testing like FSH, LH, prolactin, and thyroid profile unless she is symptomatic for thyroid disease, or ferritin test you are not going, you will just do simple CBC. Okay, so why they told not to do ferritin test? Definitely because you have history that patients having losing the blood, so that's mean she's definitely having iron deficiency anemia. So why to waste the resources to do ferritin test when you know clinically that this is because of iron deficiency anemia? Okay. So investigation for the cause of heavy menstrual bleeding. What investigation you will do? Okay. Before starting the investigation, you consider starting pharmacological treatment for heavy menstrual bleeding without investigating the cause. If the woman's history and or examination suggest a low risk of fibroid, uterine cavity abnormality, histological abnormality, or adenomyosis. For example, if the patient came to you heavy menstrual bleeding, okay, and you examine her for some reason because maybe she told you that she has pain or she has some problem, then you accordingly you offer physical examination. On examination, you find anteverted uterus, normal size, no adnexal pathology, and on speculum you find nothing, local examination nothing. So in these cases you will give the patient the first line treatment, because in these type of cases which looks clinically normal, even no ultrasound is indicated. So the woman history and examination, when deciding whether to offer hysteroscopy or ultrasound as the first line investigation, you need to take woman history. Okay. Now, if you are suspecting that women with suspected submucosal fibroid, polyp, or endometrial pathology, in these cases, how you will know? Because maybe patient will give you that she has intermenstrual bleeding, or maybe she has a pain, or maybe she has lower abdominal pain, maybe she has pressure symptoms. Then you will understand maybe she has some, maybe she has some pathology. So in these cases, you will offer outpatient hysteroscopy to women with heavy menstrual bleeding if their history suggests submucosal fibroid, polyps, or endometrial pathology. Why? Because they have symptoms such as persistent intermenstrual bleeding, or they have risk factor for endometrial pathology. Okay. So either you offer them hysteroscopy because maybe she's diabetic, maybe she's hypertensive, obese, nullipara, infertility treatment, maybe risk of endometrial pathology. So on the basis of risk factor or on the basis of symptoms, persistent intermenstrual bleeding, you will offer these patients the hysteroscopy. Now, ensure that outpatient hysteroscopy services are organized and the procedure is performed according to the best practice. When you decide that you will do outpatient hysteroscopy, what you need to do, you have to advise the woman to take oral analgesia before the procedure, okay? And the vaginoscopy is the standard diagnostic technique using miniature hysteroscope, which is 3.5 mm or smaller. This is the latest update. Before they are saying hysteroscopy, now they are saying vaginoscopy. Better, instead of putting the speculum directly, just enter the hysteroscope, which are very small hysteroscope and flexible hysteroscope. Outpatient hysteroscope, usually they are flexible. 3.5 mm small, you just use them. And also if you should also be able, when you see any pathology, you can progress to treat in this same setting. So this is the requirement when any time you are planning to do outpatient hysteroscopy. Okay, so then you need to definitely tell the patient procedure risk and possible alternative. And if patient she declined that she don't want outpatient hysteroscopy because this is only analgesia, oral analgesia, you can offer them under GA or regional anesthesia, or even you can consider pelvic ultrasound. But you have to explain that the technique for pelvic ultrasound for detecting uterine cavity causes of heavy menstrual bleeding is limited, because in some cases ultrasound is not picking the polyps, or some cases they are not good. So hysteroscopy is diagnostic hysteroscopy is the gold standard. But if the patient refuses everything, then you can offer them pelvic ultrasound. So this guideline, when it came before it, for us it become very difficult, because here we are doing routinely pelvic examination for every patient. Routinely every patient we are going to do pelvic ultrasound, and we are not doing hysteroscopies in our majority of setups. But here, after this guideline, they are saying, because they have outpatient hysteroscopy available, they are saying instead of doing pelvic ultrasound, if you are considering structural abnormalities, pathology because of risk factor, because of history, better to offer them diagnostic outpatient hysteroscopy. Okay, and if patient refuses, then you can offer them under GA or offer them ultrasound. Okay, then it doesn't mean that you are doing hysteroscopy, you have to take biopsy also. You only consider endometrial biopsy at the time of hysteroscopy who are at high risk of endometrial pathology. For example, if women have persistent intermenstrual bleeding or persistent irregular bleeding, and women with infrequent heavy bleeding who are obese or having PCO, in these patients, you have to remember this one, all those indication. Persistent intermenstrual bleeding, persistent irregular bleeding, or women with infrequent heavy bleeding. Okay, but they are obese and they have PCO. They are high risk for endometrial cancer, or if the intermenstrual bleeding, maybe postcoital bleeding, maybe CIN, okay, or maybe any pre-invasive diseases, persistent intermenstrual. So in these patients, you have to offer the endometrial biopsy. If the patient is taking tamoxifen, and if the patient is whom treatment have been unsuccessful, so in these situation, then you will offer the endometrial sample in the context of diagnostic hysteroscopy. Do not offer blind endometrial biopsy to women with heavy menstrual bleeding, because we know that in heavy menstrual bleeding there are some causes. We know that maybe fibroid, or these cases you are not doing just blind endometrial biopsy to women with heavy menstrual bleeding. Okay, only you will do biopsy if you give the treatment, and after whatever 3 months or 6 months of medical treatment, if the treatment is failed, then you will offer the biopsy. So not all the patient are for biopsy, only the high risk patient, or if they are taking tamoxifen, or if they have failed medical treatment. In these cases, then you will. So you can see now, the patient is doing diagnostic hysteroscopy. Even if you are offering them diagnostic hysteroscopy, even then you will not take biopsy unless it is indicated. So women with possible larger fibroid, definitely you do examination and you think that she might have a fibroid. What you will do in this cases, because you take the history, she give you that I have pressure symptoms, or I have bowel and bladder symptoms. Okay, I have this one, and you examine, then you offer her examination. On examination, then you suspect looks like fibroid to me. Okay, then in this patient you will offer the pelvic ultrasound. Okay, and if their uterus is palpable abdominally, if history or examination suggest a pelvic mass, or if examination is conclusive or difficult. For example, if the woman is obese and from the history you thinking maybe she has big fibroid, in these cases you will offer the pelvic ultrasound. Okay, now if you have women who, when you are suspecting the adenomyosis, how you are suspecting the adenomyosis? Definitely from the history. Though you will offer the TVS in preference to transabdominal ultrasound MRI to women with heavy menstrual bleeding. If the patient have significant dysmenorrhea, period pain, or bulky tender uterus on examination that suggests adenomyosis. If in the history there is a dysmenorrhea, or if there is a tender uterus, then in this case, instead of pelvic ultrasound, you offer the TVS, because in the TVS, adenomyosis looks better. MRI, because it is more invasive, this modality. So if the woman declines TVS or it is not suitable for her, then you consider the transabdominal ultrasound or MRI, explaining the limitation of these techniques. And also be aware that pain associated with hemimenstrual bleeding may be caused by endometriosis rather than adenomyosis. So a limitation of MRI, actually they said that if the TVS is done by experienced ultrasonologists, the MRI and ultrasound TVS is almost the same. Okay, so if for MRI, I don't know why they are saying restricted, because MRI is the one who is for adenomyosis is the best one. But I don't know, here they write the limitation of these technique in case of adenomyosis. So TVS is the best one. Okay, so what are the other diagnostic tools? Do not use it as a first line diagnostic tool for the heavy menstrual bleeding. What are these modalities? Don't use saline infusion sonography. Don't use MRI as a first line diagnostic tool. Don't use DNC as a diagnostic tool for the um, heavy menstrual bleeding. Just 1 minute. Okay. Okay. So information for women about heavy menstrual bleeding and treatments. You will give the information according to NICE guideline on patient experience in adult NHS services and shared decision making. You have to provide the information. Okay. And then after that, what you need to discuss the benefit and risk of the various option, a suitable treatment if she's trying to conceive. Now you have to think about the fertility issues also. Also whether she want to retain her uterus or her fertility. So these are the options or informations you have to give to the patient. Okay. So now Marina. Marina explained to the women who are offered in Marina about anticipated changes in bleeding pattern, particularly in the first few cycles and maybe lasting longer than 6 months. So whenever you are putting the Marina, inform the patient that the first 6 months, if any spotting or irregularity or infrequent period or more frequent period, it's because of Marina, and it's you will not, you have to explain, and there you can add the treatments. For example, if she has frequent bleeding, you have to give them NSAIDs. This is part of the counseling. For 6 months you are not going to do anything. That it is advisable to wait for at least 6 cycles to see the benefit of the treatment. So this 6 months you have to keep in your mind. For hormonal treatment you have to wait for 3 months. For Marina you have to wait for 6 months. Okay. So what is the impact of treatment on fertility? Okay. So impact of fertility, you have to explain the patient that any planned surgery or uterine artery embolization may have impact on fertility, and if a possible treatment, for example hysterectomy or ablation, involves loss of fertility, then opportunity for discussion should be made available. So for example, if you are offering her myomectomy, or if you are offering her uterine artery embolization because you want to retain her fertility, you have to explain the impact, because this is not 100%. And also if she is having this one maybe hysterectomy or ablation, also it involves the loss of fertility. Okay. Explain to the woman that uterine artery embolization or myomectomy may potentially allow them to retain their fertility. So these two modality you can offer to the women who want to retain their fertility. Okay. So endometrial ablation, advise women to avoid subsequent pregnancy and use effective contraception if needed after endometrial ablation. So endometrial ablation, still there is a chance the woman can conceive. So after ablation, patient have to use the contraception. Okay, so this is not 100% uh, she can avoid the pregnancy. Still there is a chance of having pregnancy. So she has to use the effective contraception. Hysterectomy, have a full discussion, because you need to tell the patient that in hysterectomy, what will happen to the sexual feeling, what will happen on the impact of fertility, bladder function, further treatment needed, treatment complications, her expectations, alternative surgery is available or no, psychological impact. So these things you have to cover. Okay. Okay, so you need to tell the patient that the hysterectomy, there is an intraoperative hemorrhage or damage to the other organs. Also, if especially when you are doing hysterectomy for multiple uterine fibroid. Also, she need to be know that there is a possible loss of ovarian function as its consequences, even if the ovaries are retained during hysterectomy. So these are the information you have to give. Okay. Now management. Now we will discuss the management. Whenever you are giving the patient treatment options, you have to see what the woman wants. Maybe in the MCQs or EMQs, the patient have some type of preferences. Maybe they will give you, the patient don't want injectables, the patient don't want marina, or patient is the cardiac patient or something like that, or patient don't like to take pills. So you have to see what the patient, what the woman preferences. Any comorbidities, if the patient has obesity or nulliparity, infertility treatment, or any comorbidity she has, and the presence or absence of fibroid, polyps, or pathology or adenomyosis, and then other symptoms if she has pressure or pain. So these things you have to keep in your mind before prescribing any treatment. Okay. So the treatment for women with no identified pathology on history, on structure, on physical examination, and you, or if she has ultrasound, if or if she has hysteroscopy and his fibroid is less than 3 centimeter, or suspected or diagnosed adenomyosis, in these cases what you will offer Mirena as a first line. So first line treatment, if the patient have no identified pathology, even from the start, if the patient came to you and you think it is a low risk, and even without doing hysteroscopy or without doing the other ultrasound, you just do physical examination and you can offer her Mirena at the first line. Okay. Or if she has fibroid on ultrasound, or if she's having on TVS, she has diagnosed adenomyosis or suspected adenomyosis, the Mirena is the first line. Okay. Especially you will put the Mirena with no identified pathology or fibroid less than 3 centimeter, which are not causing distortion of the uterine cavity, or suspected or diagnosed adenomyosis. In these cases, you can give Mirena as a first line. Okay. So if the woman with heavy menstrual bleeding, if the woman with heavy menstrual bleeding declines and Mirena, or it is not suitable, consider the following pharmacological. If she don't like Mirena, okay, you have other treatment which is hormonal, sorry, which is non-hormonal and then hormonal. Maybe a patient want to conceive. In this case, you can offer this patient the tranexamic acid, not NSAIDs. Why? Because NSAID will cause the luteal phase, I think, unruptured follicular syndrome. So NSAIDs you are not giving to the patient who want to conceive, but tranexamic acid you can give. So according to the scenario, you can offer her non-hormonal treatment. And there are questions in which they'll say patient don't like hormonal treatment. So in that scenario, you will select the tranexamic acid. Okay. So I will just mute somebody, because mute all. Yes. Okay. Hormonal treatment is OCPs and cyclical oral progesterone. Okay, now if the patient have a fibroid which is 3 centimeter or more than 3 centimeter, what you will do? Okay, what you will do? Um, so treatment for women with fibroid of 3 centimeter or more in diameter, you will refer this patient to specialist care, so they can have additional investigation and they can discuss treatment option of fibroids of 3 centimeter or more. If pharmacological treatment is needed while investigation and definite treatment are being organized, we can offer tranexamic acid and or NSAIDs. So we can offer this patient who is having fibroid more than 3 centimeter, and there is no limit, more than 3 centimeter, maybe 10 centimeter. But the limit of Giving medical treatment is 3 centimeter, but if she's waiting for to be shifted or to be organized or referred to the higher center for therapeutic hysteroscopy, you can still offer her tranexamic acid and or NSAIDs, and advise women to continue using NSAIDs and or tranexamic acid for as long as they are found to be beneficial. So there is no limit of how long she can use tranexamic acid or NSAID. Maximum 6 months, definitely, because more than 6 months, it will be considered as failed medical treatment. Okay, so women, if the have fibroid more than 3 centimeter, you have to see where is the size, sorry, where exactly it is located, what is the size, how many numbers, and what severity of the symptoms. So accordingly, for fibroid more than 3 centimeter, you can offer again non-hormonal treatment, which include tranexamic acids and NSAID or hormonal treatment. Okay, or you can offer Mirena, a combined hormonal contraception and cyclical oral progesterone. So even in this case, 3 centimeter, if the fibroid is subserosal, okay, then definitely maybe it is not distorting the endometrial cavity. Even 10 centimeter, it is not distorting the endometrial cavity. In this case, you can offer the Mirena, because what will happen with Mirena? The size of the bleeding will be less, and because of less bleeding, maybe patient will get the benefits. But anyhow, Mirena in this case, while she's waiting for referral, you can offer her Mirena also if the cavity, but depends on the size and location and number of fibroid. Not all patients. Non-hormonal tranexamic acid and NSAID, hormonal is combined Mirena and the cyclical progesterone. Okay. So ulipristal acetate, this is only indicated for some premenopausal women. Before, I think this guideline came in 2015, I think, or 16, I don't remember exactly. But now they updated 2018. They said it is, before they said it should be stopped because it will be MHRA. They say it is maybe related to liver dysfunction, liver problems. The patients are having liver problems. So they banned this drug. But now they said you can use this one. This is only indicated for some premenopausal women. There is some indications. Okay. Okay. This is the continuation of this slide. Today my slides are vertical. I don't know why. Okay. So this is pharmacological treatment. Okay. This is number one treatment. Pharmacological treatment for women having menstrual bleeding with fibroid more than 3 centimeter. You can offer pharmacological, which is non-hormonal, hormonal, including the Mirena, and it will include the ulipristal acetate. Then you have this uterine artery embolization for fibroid. This is the second option. Then third option is surgery, which include myomectomy or hysterectomy. Only think about ulipristal acetate for the intermittent treatment of moderate to severe symptoms of uterine fibroid in premenstrual women if surgery and uterine artery embolization for fibroids are not suitable because the risk to the woman outweigh the possible benefits, or surgery and uterine artery embolization have failed, okay, already she has myomectomy or already she has uterine artery embolization, but it is failed, then, and also women don't want surgery and uterine artery embolization. So either women don't want, either women have failed, or either woman is not suitable for surgery or uterine artery embolization because of some reason, you will offer this patient ulipristal acetate only in the selected cases, okay, not all patients. Okay, so what time now exactly? Okay, we will continue this lecture tomorrow, okay, because I just make in a hurry in this lecture. What we will do tomorrow, we'll continue this lecture, and then after that, I will see that we want to discuss postcoital bleeding TOG, or either there is a TOG article for fibroid modern management of uterine fibroid. We'll do, but before reading that talk article, you should know that what the NICE guideline is saying, that because NICE guideline is the more latest one. So we need to discuss, and because this guideline, I need to, I didn't make, I only make the half guideline, okay? Because I don't have time today. So you need to ask anything regarding this lecture for today. Any
Yes, ma'am.
questions?
I want to ask one thing.
Everything is
You
clear?
have said that, yes, ma'am, everything is clear, but one thing I want to ask,
Okay.
that if patient comes to me and she is more than 40 and she is having heavy menstrual bleeding, I will take history and I don't find any other cause, and I'll do abdominal examination and I cannot palpate the uterus abdominally. So should I go for examination, or straight away I should start Mirena? That is a little bit confusion, because as you rightly said, that on every patient in Pakistan we are doing pelvic examination. But you said that pelvic, we should not do pelvic examination in a low risk patient. But if she is 40 years of age and she is having heavy menstrual bleeding, so what about her? Shouldn't we investigate her to rule
That's
out
why I
endometrial
will tell you, if
CA?
heavy menstrual bleeding, actually heavy menstrual bleeding is a cyclical bleeding which is regular and which is only heavy either in amount or in days. Okay, so most likely the
Okay.
pathological causes like cancer or other causes which are indicating that structure problem. For example, maybe submucosal fibroid, it will cause irregular bleeding. So when you are saying heavy menstrual bleeding, the patient is saying she has regular heavy menstrual bleeding without any pain, without any pressure symptoms, then most likely either it is of a fibroid or either it is because of bleeding of endometrial origin. Either this one, either this one. So in this case, just because you are sitting in the OPD and in your history, even if she's 40 years, because I think the cutoff point is 45 years for endometrial CA. Less than 45 years, the risk of endometrial CA is very less, and more than 45 years it increases. So less than 45 years, if patient have heavy menstrual bleeding, not abnormal uterine bleeding, heavy menstrual bleeding, even then you take history and she's low risk, and you just write for her, ask her and write for her tranexamic acid or ibuprofen, or if she's not want this one, you can write for her OCPs or progesterone according to history without offering physical examination. That's it. If she don't have any family history of endometrial CA, she's not
Okay.
obese, she's not hypertensive, she's not diabetic,
Okay.
just like that you will not do. Or if you want to decide, no, this patient is good for Mirena, why not to put Mirena, then you said, okay, let me examine you, better to take
Okay.
Mirena because it's first line. Okay,
Okay. Okay. Thank
I
you.
know this guideline is very confusing because it's totally
Yeah,
different
definitely.
from, yes, totally different, but
Yeah,
be careful because in the
it's
exam,
very strange, because
yes,
most of the time people are with reports, with ultrasound reports, because first investigation they always do is ultrasound,
yes,
and they all
mm,
and in the periphery, in the small setup, they always do ultrasound. First of all they do ultrasound, and then they approach to any tertiary care or secondary care setup, basically.
I will tell you why I was busy and why I select this topic now. I want to stop this one